Uh, Good afternoon, everyone. Thank you, Prof. Swarna, for the kind introduction. I'm Ling, a pharmacist from Institute of Mental Health. Today I'm here to share about pharmacological intervention in schizophrenia and a brief overview of the sharing. First, we'll go through why we need to treat, as in the therapeutic goals, and then when to start treating. And antipsychotic is a mainstay in schizophrenia, but with all like a different generation of antipsychotics and multiple antipsychotics around, which one to choose, which one is the first line. And after we choose antipsychotic, what to watch out for. And also about adjunct medication with the use of mood stabilizer, be it antidepressants or anticholinergic agents like benhexol, benztropine. And then we come to combining antipsychotics. And last but not least, clozapine for treatment-resistant schizophrenia, and another one is, do we discontinue antipsychotics? Why we need to treat a patient with schizophrenia? Then the therapeutic goals of treatment, of course, in the acute phase, is actually to reduce the harm or threat to the patient himself or to others, family members, or even members in the community, and obviously to reduce the acute hallucination or agitations or negative symptoms, depression, all this, and also to improve the role functioning of the patient in family, occupation, or in the community. And in the stabilization phase, this is to minimize or prevent the relapse. Relapse here is after we get patient into remission within the 6 months of after the acute phase. If the symptoms come back again, we consider it as relapse. And then for the maintenance phase, the goal is actually to improve functioning and also the quality of life. And to maintain the baseline functioning of the patient, prevent deterioration, and also to optimize the dose and try as much as possible to minimize the adverse reaction to the antipsychotics. So when do we treat a patient with antipsychotics? As soon as we rule out the organic cause of psychosis, we should start the patient with antipsychotics. And then, so we have a group of patients who is newly diagnosed with schizophrenia or first episode patient. This study has shown that if we treat the patient earlier, the response rates actually ranging from 46 to 96%, and is critical in achieving good long-term outcome. What is a good long-term outcome here? So it means symptoms remission, delay deterioration, and also to prevent relapse or recurrence. And the first episode patients, they are usually more sensitive to the therapeutic dose or the side effects of the antipsychotics. So if we were to start a patient, a new first episode patients with antipsychotic, we should actually go slow, start with a lower dose than the normal therapeutic dose for a chronic schizophrenic patient. And when the patients on maintenance phase and with acute relapse, antipsychotics are efficacious, and it's actually have been shown that it can induce remission in about 70% in the acute relapse. So maintenance phase, patient already on antipsychotics. So it's time to review whether patient is compliant to the medication or the medication is no longer efficacious. So there's a time that we need to think whether we to increase the medication or to change the medication. So which antipsychotic to choose? We have typical antipsychotics with whole lots of antipsychotics, oral like carbamazine, haloperidol, trifluoperazine, depot injection like flupentixol, fluphenazine, piperacillin. To choose typical or atypical, a whole group of atypical also, amisulpride, aripiprazole, the latest azathioprine, paliperidone. Then for the depot injection, we have risperidone consta, we have paliperidone sustainer. So many out there, so which one to choose? Is typical better or atypical better?